Laser pointer in advance, got it. Hi, thanks everyone for having me, this is cool. I realized something that I need to mention from watching Dr. McGuire's presentation is that I too have a disclosure that I'm not financially tied to any of the things I'm going to mention, but I am willing to be purchased if anyone wants to do that. So if the AHA wants a bumper sticker or something on my car, I'll wear a shirt, jacket, you guys can buy me. Times are tough out here. Oh, that's that part. I didn't know that's going to do that, but that's all right. There we go. We're going to skip this because I'm sure at this point of the day you guys are all well aware of what ICH is. I'm going to talk about this just because I think my history aspect on it's a little different than most of you have probably learned. And the Monroe-Kelly hypothesis is a huge part of what we do in the neuro ICU, taking care of patients, and nurses need to understand. So it was first described by Marilyn Monroe, right? The late Marilyn Monroe, and then later perfected by the talented Kelly Clarkson. And it basically says that you can only have three things in your brain at one point: brain, cerebrospinal fluid, or blood. One of those things go up, something else has to go down, or stuff gets smushed, and that's not good. But jokes aside, I think karma's bad if I don't give the right people credit who did this. So Alexander Monroe Secundus and George Kelly are the ones who actually, Monroe first developed it, and then Kelly expanded on it. So down there, I'm not sure where they are. Don't haunt me. Don't haunt me. We don't know. They're brilliant neurologists. We don't know if they're good people. They could be down there. Moving on. So cerebrospinal fluid, your body does have some compensatory mechanisms that it can use to help protect itself, but those fail eventually. Some of these are they push out cerebrospinal fluid into the paraspinal space, and then other ones are the venous system will push that blood into the extracranial venous system as well, and it also will decrease the production of CSF best it can and try to reabsorb some CSF. Those eventually will fail, and then ICP rises, and then that's when we need intervention, which we just learned a ton about. Herniation, bad. Surgical interventions, we know all about those. We just listened to a bunch of that. So I'm going to do a famous case study to try to tie this together. I have a 2-year-old, and so this is very much in my life right now. So 5 pediatric patients were jumping on a bed, and we all know it. One fell off, bumped his head. Mama called the doctor. Doctor gave terrible medical advice and just said, don't jump on the bed anymore. So doesn't really help this current monkey that fell off the bed, but I guess all future monkeys, it could help them. Unfortunately, the monkeys kept doing it. More monkeys kept jumping, kept falling off the bed, kept hitting their head. Monkeys kept hitting their head. Finally, the last monkey fell off the bed, hit its head, called the doctor again. The doctor said, all right, put those monkeys straight to bed. Again, not really the best medical advice if TBI is of concern, but mom did it. They all went to bed, and next day, woke up, and unfortunately, one of the 5 monkeys was unarousable, so the mom called 911, and the patient was taken to the nearest comprehensive stroke center. Got dark quick there. Stay with me. Nurses rolling post-op. I have these mixed up. So the case study, pediatric monkey, GCS of 7 on arrival, intubated, and stat CT revealed large left temporal traumatic ICH with IVH extension, taken to OR for craniotomy evacuation, EVD placement, post-op in the neuro ICU. Jump back here. So the nurses rolling post-op. That's what I'm really going to talk about mostly here. Biased, but I think it's a safe place to share this opinion because we're here for ICH conference. I think the brain's the most important organ. I do, and not to get too philosophical, but if there ever was an organ that houses a human soul, I would say it's your brain. It's who we are, it's our memories, it's the difference between like what we do in neurocritical care, the difference between someone going home and knowing their family, creating memories, enjoying life, or being in like a long-term acute care facility. So it's really important what we do second to second. There's no machine that runs your brain. There's no transplant yet for a brain. So you get one and that's all you get. So a lot of things that we do in the neuro ICU are the monitoring, neuro checks, ICP, vitals, medical management, huge part of what nurses do, patient positioning, a very large part about what we do with patients, especially with traumatic brain injury patients or any confused patient. It's very difficult to get them to sit perfectly, so nurses do a lot of that. Family education, we're usually the ones there most of the time with family, and then documentation and making sure everything gets put in there. But it's just kind of team effort. Everyone kind of does that really well. All right, back to this, and then we're moving on. So the neuro exam, bread and butter of what makes a neuro ICU special. That's kind of how it goes too. It's like, wake up, and you pinch them. So usually involves Q1 hour neuro checks, We do LOC, orientation, vision, pupil reactivity, motor strength, sensation, all those things. And the nurses are with them for usually 12 hours at a time with close surveillance, and you're monitoring for any kind of signs of rebleeding, worsening neurological outcomes, all those things, hydrocephalus, any of those things, and then you bring it to the attention of the provider, and you usually go on a CT scan to see if anything's changed. Another thing that we added recently within the last couple of years to our neuro ICU is a device called pupilometry. Phenomenal device where, I don't know if it's been spoken about today yet at all. No? Oh, cool. All right, I'll be the first one to share it with you guys then. So flashlights, you can probably get rid of them if you just have this device. It will pick up something called an MPI number, neurological pupil index, and it measures this based on pupil size, constriction velocity, dilation velocity, and latency, and it calculates this MPI number. Using this number, it takes away all subjective assessment of someone's pupils, and it's actually a really good indicator of compression of ocular motor nerve 3 and 2, so it gives you signs of if someone's having compression of those areas in their brain, sometimes before you have any other neurological changes happening, and you can trend it throughout the whole patient's stay. So it's something we started implementing, and I know some other places, a lot of comprehensive stroke centers are using them in all of their units as well, and a very valuable tool. It's always in conjunction, or adjunction I should say, with all the other things we do. You can't just say the MPI is this. It always goes back to that neuro exam. What's the patient doing neurologically? But it's just a nice extra added piece of information that you have. Limitations to it are location, so it all depends on, like, if you have a really distal subcortical lesion, it doesn't do that good of a job because it's measuring compression of those lower cranial nerves. But yeah, really cool device. I'm a big pusher of it whenever we have patients to add it. So patient positioning, ICP management, just a lot of things that we do as bedside nurses. Patient positioning, EVD management, medical management, airway and ventilation, hemodynamics, temperature management, glycemic control. This was a tough thing for me to narrow down to do this presentation because I feel like I could have talked for hours on just all the things that nurses do, so I try to just kind of like hit the key principles, I think, of what's caring for the post-op ICA patient that we do. So patient positioning, that bottom picture is a lot of the time what we see when we go into a room, and it's always the worst thing you can see for your ICA patient, but they move around, they wiggle. Bed alarm doesn't always pick this stuff up. We try to keep head of bed 30 degrees, neck midline to allow for the venous drainage. Utilizes the spinal buffer, which I'll show you a picture of in a second here. And then it allows, like I said in that earlier picture that we looked at, where the CSF can go into the paraspinal space, and then the jugular veins allow for drainage of the venous system. Proper alignment is needed for this, and we also try to avoid, I wasn't sure where to put this, so high stimulus environments, try to cluster our cares as well, because that can increase ICP. This is a nice picture of the spinal buffer. All literature that I've looked at usually says there's no added benefit to sitting the patient up higher than 45 degrees, like 30 to 45 is what you want to shoot for. My understanding, and it's nice that I'm here at a place where all these people can correct me if I'm wrong, but my understanding is that if you put someone up at 90, it does help decrease ICP, but there can be some negative consequences due to hypoperfusion if autoregulation is disrupted from the brain injury. So 90 degrees isn't always beneficial to sit someone up that high. This is another really important thing that we do in the neuro ICU. I made this picture myself, so if anyone needs memes made, I can do it. This one cracks me up because the EVD, I think, and again, biased, I've worked for 10 years now in neuro ICU, it's such a simple device, but it scares everyone so much that doesn't work in the neuro ICU. And it's not harder than CRRT. I don't think it's more complicated than balloon pump, but no other nurse wants to go near the thing. And it's just like a stopcock that goes like this, but I don't know. But usually bad things can happen if you mismanage it, but to manage it's not that hard. Q1 hour drainage output and the ICP is what we usually do in the neuro ICU. And again, the nurse is the one keeping their eyes on this for their 12-hour shift or 24/7 when you switch over to night shift. And prompt detection and interventions for ICP, that's sustained. Usually above 20 is what our orders will say. And then always looking at color, drainage amount. And our nurses are all taught to understand kind of the normal production of cerebrospinal fluid and understanding. The orders are put in pretty clearly too. If like drains this much in this amount of time, please call. But it's also good to understand because when blood's mixed in there, 20 mLs out maybe doesn't mean they're obviously losing 20 mLs of CSF. It's a mixture of things and we want the blood out. So it's not always the worst thing, but you make about 30 mLs roughly an hour. You have about 250 to 300 floating around there, and then at any given time you make about 500 to 600 a day. So it's just important principles to know when dealing with these. Fluctuation, another really important one because you want to make sure it's patent. A lot of blood that that happens with EVDs in their tubing can clot them off, and then they're not working, they're not draining. The ICP waveform, which I'll show you a picture in a second, and then just maintaining the drain at the appropriate level, which is sometimes a pretty big challenge for us as nurses because patients love to slide down or squirm. Obviously, the most dangerous is if they pop above the EVD and they're above the level where it's supposed to be. Below is not good either, but a little bit less urgent, I guess, to fix that. It just doesn't work the way it's supposed to be because it's supposed to be draining at a certain level. So this is the proper level of the EVD. I'm not a neurosurgeon, so I've never actually been inside the brain, but I'm sure Dr. McGuire can attest to this, that I can't find a picture. So you level it at the tragus, which is supposed to be in line with the foramen of Monroe that Marilyn discovered. And, but this picture obviously doesn't show that. Like the foramen of Monroe is not where the level is, but that's like when you look at the literature. So I've never found a good picture that shows this. I don't know. Am I right or wrong? Sure. All right, cool. Yeah, I like this. Teamwork. Yeah. This is perfect. This is why I don't have to know anything, actually. Finish my PowerPoint for me. Huh? Oh, yeah, give her a mic, yeah.
Sorry. All right, it's right there. That's foramen of Monroe.
Yep.
There, and that's the tragus.
But shouldn't they be in line with each other per
They
books?
are. But like that's the level.
Oh, but it's like 2D, so it's confusing.
Yeah. Yeah.
All right.
There, you got it.
Kind of. All right, thanks. I got 2 mics now. Oh, okay,
First take, team.
All right, there you go. There you go. Nice. All right, I'll put you on the front slide now. And then, yeah, the foramen of Monroe is a little better picture. The interventricular foramen there on that picture there. ICP waveforms. So this is another complicated one, which actually maybe we should just bring you back up here, Dr. McGuire. But so all the people I've ever spoken to about this to try to really learn about it, because it is a little confusing, is how I've always been curious how the waves are produced, how they actually come about. So P1, percussion wave, systolic, it goes up there and then through the choroid plexus, it's like sensed on the catheter tip and it gives you that first little P1 spike when we're looking at the green waveform right here, a normal ICP waveform. And then P2, and this is my understanding of it, which I'm gonna nursify it here, is it's that same pulsatile waveform bouncing off the inside of the brain and then coming back and hitting that catheter tip again, and it gives you P2. So P1, P2 relationship represents cranial compliance, and if you're able to handle increases in ICP. So a tighter brain that's under pressure will give you a bigger, which you see there with the P2 higher than the P1. That's my best way of understanding it. And then the dicrotic wave, P3, is just the closure of the aortic valve, and that sends a little pulsatile waveform up there and gives you that little blip at the end. Yeah? Yeah, I got a nod. All right, cool. All right. That's my best way of understanding it. It's hard to find. It's like not something you can just Google. Medical management, huge part of what we do. Doctors order all the medicines that are needed. There's a lot of standing orders, and then nurses are the ones delivering the medications to the patient and titrating and monitoring and all of that. So a lot of times in ICH patients, the important thing that we're doing is lowering blood pressure. So a lot of vasoactive medications, vasodilators, cardine usually is our drug of choice at my hospital. And we're usually trying to lower blood pressure to set parameters by the team, which is around 140 systolic in most cases. And just making sure that we don't rapidly drop blood pressure too far. So it's a very delicate balance because then we decrease cerebral perfusion, which we'll talk a little bit in a second. Providing adequate sedation and analgesia, another very delicate balance that needs to be done because you don't want to lose your neuro exam, but then you also need the patient to remain calm because if patients, like we talked about earlier, high stimulus or pain can increase ICP and make things worse as well. Q4-hour sodium draws is another thing. We're really always very hyper-fosed on what our patient sodium levels are, and in a lot of patients' population, we will actually have sodium goals or we'll administer hyperosmolar therapy. Usually it is in hypertonic saline is how we do it in our hospital, but mannitol is something else that we will give as well. Airway and ventilation, this picture cracks me up. Any TV picture of someone intubated in CPR never works out. So I always think this is funny. Anyone know what movie this is from? Extra points? Anyone? No? The Vow, yeah, nailed it, nice. All right, give her a goodie bag too, Sue. She earned one. It's funny because it's like the producer's like, hey, what do you think we should do? Should we get a medical expert on this movie? And the director's like, no, just have her suck on a vacuum, it'll be good. That's what I feel like they did with this movie. But anyway, intubate for anyone with depressed GCS, can't protect their airway. So that's usually what happens in these types of patients, and adequate oxygenation and ventilation to avoid hypoxia or hypercapnia, or hypocapnia as well, actually, to make sure that we're keeping patients in that delicate balance to prevent secondary injury. So hypoxia exacerbates neuronal injury and worsens outcomes. We know that, and then we want to maintain the PCO2 in a normal range at all times because hypercapnia is a vasodilator, so it can increase ICP, and the hypocapnia can cause vasoconstriction and decrease cerebral perfusion. So those are two things. And then we want to try to have minimal PEEP settings if we can too, because that can also increase ICP or mean airway pressures. We can keep those down as well. So the nurses, with partnership of RT, was always monitoring and managing the ventilator as well for our patients. Hemodynamics, this is a real tricky one, and I'm waiting for the day, and I think I'm going to see it in my lifetime, where there's going to be some really cool monitoring devices that we can really pinpoint our hemodynamics for individualize each patient. We're getting close, I feel like, with some of the oxygen monitoring that they have and stuff, but just not there yet. So the brain's about 2% of the total body weight, and it receives roughly like 20% of your cardiac output. So early and careful and sustained systolic blood pressure lowering and management is really important. We just kind of talked about it. We try to keep it in that 120 to 140 range in the initial acute phase of ICH during the first 24 hours, and then when we know it's more stable, then our MDs make the decision to liberalize blood pressure parameters. You really want to make sure that you don't drop them too suddenly, and I just did my TCAR this year, and something that really stuck out to me in that course that I took was that one instance of SPP, your systolic blood pressure dropping below 90, just one time doubles your mortality, which I thought was like, whoa, that puts a lot of pressure on you not to do that. It does, yeah, you're like, oh no, it went below 90, it's bad. So something we're always looking at when someone has an EVD, which is really nice, is we get an ICP. Your MAP minus your ICP gives you your cerebral perfusion pressure. Best outcomes, keep it around that 60 to 70, which is all in the orders and the nurses are monitoring. And I guess there are some instances where they can individualize CPP for certain things, but not all the times. Usually that's 60 to 70. And yeah, that's all the stuff, I believe. Yeah. For temperature management, another trickier one with patients with brain injury. Always trying to maintain normal thermia, treat fever aggressively, given that it exacerbates neuronal injury and makes secondary injury worse. So we always want to make sure that we keep that under control. Usually we get away with it pretty well with medical management, but on the occasional time we will implement external cooling devices, not affiliated with the company, but Arctic Sun's what we use at St. Luke's, and it is a really good device, and it does a really good job at keeping, well, I'm kind of affiliated with, not really, no, I'm not, never mind, disclosure, never mind, I'm not. I don't make any money. So a temperature greater than 99.5 is considered fever because the brain can be a little warmer than the body, so we make sure that we don't let our patients get above 99.5 that are at risk for hyperthermia. And then the nurses will manage all of the complications if we do initiate targeted temperature management, which is like shivering, infection, stuff like that. Glycemic control, again, brain's only about 2% of total body weight, but consumes about 25% of the body's total glucose at rest. So if you're like a super smart person, Dr. McGuire, is probably more like 30 or 40. Someone like me, probably 10%, which is an easier way to live your life. But we try to maintain normal glycemia at all times, and it's just most of the time for the nursing staff, it's just frequent blood sugar monitoring, and then if patients need something else like insulin drip or sliding scale insulin, we're the ones that will monitor and administer that as well. So, real life application. So nurses carry out all orders. We catch what's missed, it's the subtle neural changes. We missed orders. We're always partnering with our providers to make sure that all the things are being done, because there's a lot of times where things get said and then doesn't always get put in the chart, and we just make sure that all those things are in place so that the patient gets the best care that they can. And then we advocate for imaging and escalation if we think something's going off. And if you've been a neuro ICU nurse long enough, most of the time you can intelligently describe to your providers what's going on, but sometimes just like they're off, and it's sometimes just enough to get the CT and figure out, or if the patient's family member says they're off too. And then we document everything, we keep it good. So my goal as an educator at St. Luke's, I've been one for about 4 years now, is I try to empower all of our newer nurses, the next generation of nurses, to be like proactive instead of reactive. Like the more you know, there's such a knowledge gap that you get from nursing to all other aspects of neurocritical care, and you really have to be the one, if you understand these principles the best you can, try to get to that level of provider, it just makes patient care so much easier and better for everyone. So that's like always my goal. And I've spent a lot of time with education videos and stuff for our new nurses. So medicine is not just about what you do, it's about what you don't do. Let's make sure our monkeys get the care they deserve, and don't let them jump on the bed. I think that's all I got. Questions? I was fast. I talk fast when I get excited, so I go a little fast. I went fast. I can share a story quick too if I got to take up time, but I don't know. Do I? Are we good? I'll share one. So my mom recently, I'll share one. This one's not that funny, but it's all right. My mom recently had ended up being AVM rupture, but I'm from the East Coast and she was out east, and I didn't get a woo. No woo? No, okay. That's all right. You got a woo. But so she was out east, and so I had to deal with centers out there, which is a lot different than what I'm used to here. And I just assumed all comprehensive stroke centers are kind of on the same level playing field. And I was talking with our neurosurgeons here at St. Luke's, and they were all offering like early port-assisted evac is what they said when they looked at my mom's scans. And initially, it was chalked up as being spontaneous ICH from hypertension. My mom's a very healthy person, so I don't think it was that. I didn't think it was that from the start. But then the next guess was it could be an underlying tumor that bled. She'll get discharged, and then if after like 3 months or so when the blood clears up, we'll get MRI and you can see what we're dealing with and then go from there. So she went to rehab, and then she ended up rebleeding in rehab, and then eventually we got her, and at this point, the rebleed, her symptoms were much worse. She was flaccid on her left side for a week and a half before we were able to get her out to someone that was capable of doing port-assisted evac with functional MRI and stuff like that. And we got her out to a doctor here who our second floor at St. Luke's was originally built for, who was kind of in the beginning of all the pioneering of port-assisted evac and partnering with GE for the functional MRI and mapping. And he did the procedure, and after a week and a half, she was flaccid on her left side for a week and a half. And after about 2-3 hours after surgery, she was moving her hand again, which was kind of crazy. And then about, I don't know, later that night, she's lifting her arm again. It was wild. And even the doctor was like, I didn't expect it to be this good. I was like, this is crazy. And they did a story on her in Illinois, actually, because she had such a good outcome. But then she did her rehab at St. Luke's, a hospital I work at. And after about 2 weeks there, I think it was, she was back to like being almost fully functioning, went back to Pennsylvania, did a little bit of outpatient rehab, and got back to where you'd never know anything was wrong with her. She's driving, she's working. You met her on the street, you would never know this person had an AVM rupture in her brain. And the only reason we knew it was an AVM actually was because when they removed it surgically, originally it was cavernous malformation, did pathology, and they're like, oh no, it's actually an AVM. But that's where I was like kind of firsthand saw like the sit and wait, and then saw as soon as they took it out, her get better instantly. And I was kind of like, now I'm like, oh yeah, you should always just take it out if it was me. But now I'm like curious about the timing. If I'm ever in this situation, I'd be like, all right, wait 8 hours, then take it out. Like, I don't know what the timing is. But yeah, all right, there's my story. Now we can do questions. Go ahead, questions up. Anyway.
Anyone have questions for West? Please move to the microphones.
No, it's easy. All right, cool.
Wait.
Oh, no,
One
Emily's
moment.
gone.
Couple.
I know. I already sent you baby pictures.
I have a question. So earlier we were talking a lot about frequent neuro checks by nurses. What are the important key components you do education with your nurses on? Like what parts do you want them doing every 15 minutes or every hour for those patients?
Epic makes it pretty easy because all the things are in there that they're supposed to chart on. It's honestly the practice of, and this is why the stroke team is housed, the rapid response stroke team at St. Luke's is housed in the neuro ICU, it's the nuance of being good at neuro assessments. So their orientation, that 3 to 4 months that they spend on orientation, the most important thing is like those are all the things they need to do. And I always tell them, anytime your provider goes in there to do an assessment, go in with them. That's how you're gonna really learn how to classify things or call things what they are, by hanging out with the neurologist that's doing it, or your preceptor that's doing it. So I would say for orientation, the most valuable thing is just the time spent on the floor assessing actual stroke patients. Because you can look in a textbook and it says, oh, this is damage, this should happen, but that's not how it always works, you know what I mean? So it's the nuance of it. Good question, Emily. I don't think I answered it. But
how do you apply that to the emergency department?
Huh?
How do you sort of reflect that in the emergency department?
Oh, because you're saying not as thorough? Or
I'm
what are
not
you...
saying that.
Right. I don't know, it's hard because it's a specialty for a reason, so I don't know if I'm the guy that could answer that. I don't know, that's so tough. That's why we have like stroke team, right? Mm-hmm. Yeah, so I don't know if you could, it would be awesome if everyone was very skilled, because even just all other units, you have medical doctors that obviously spend all this time training, but they're not neurologists or they're not in the neuro world, and it's still kind of a, oh yeah, their arms are moving. Yeah, you know what I mean? So it's tricky.
Awesome.
Yeah.
Wondering how your unit manages, or how your nurses manage when they get conflicting orders from various providers that have had their, let's say you have a patient that neurosurgery is perhaps primary, but neurology is also involved, and you have conflicting orders, and nursing doesn't always know which one to follow because they don't necessarily either address the conflicting order, or the providers don't necessarily address the conflicting orders, and how best to manage that. Or
it's tricky. I'm a child of divorce, and so it's a lot like that. You make them talk to each other. And you try to stay out of it, because being the middle person when you're trying to take care of a patient is so difficult. So when I see that, and we're actually kind of lucky, is our critical care providers are all critical care neurologists, so they're kind of like, I don't want to say like on the top of the hierarchy, but usually they're the ones that will make, with recommendations from neurosurgery or stroke, will make the final decision. But if there's ever conflicting things like that, I always tell new nurses or myself in my practice, I don't have time to be the middleman for everything. Can you please just like talk to each other and agree? We're very lucky too that we have a lot of APCs, so they do a lot of that stuff too, and clean up orders and talk to doctors for us too. But yeah, it's a good question. It's a tough one. Yeah, it's a tough one. Anything else? No?
Thank you, Wes. That was fantastic.
Thank you very much. Put on my resume now. There you go. All right.
Appreciate you.